Yeah, probably. Yeah.
Okay. Okay, well, we'll start out where we left off before. So, here we go. Shiv, what do you think of this case? So we're talking about other causes of back pain besides disc disease.
Okay, 60-year-old man, increasing chronic back pain. So it looks like there's some facet arthropathy on the CT scan, top left image.
Irregularity, hypertrophic disease, new bone formation, a lot of irregularity and sclerosis here.
Mm-hmm.
Okay. And there's the coronal reconstruction. So, how do you know this is symptomatic? Thomas?
Whether it's symptomatic, maybe if we got an MRI and looked for edema.
Okay, well, instead what they did was this. Oops.
Oh, okay, so this looks like a PET scan.
That's a fluorine PET scan.
Okay, and then it shows
It's kind of a research technique at the time.
Fluorine, okay. And it shows uptake in the right facet joint.
Which is where the patient had symptoms.
Okay.
So they then did a steroid injection at 4-5, and the patient got substantial relief. So, but I think a large amount of back pain is from facet disease. And the problem, the reason it's not as popular as disc disease is that there's no surgical treatment really for it, and therefore it's not a big driver of revenue for hospitals. So I think it's often kind of forgotten. And people kind of want to make diagnoses for things that they can actually treat. The problem is that if you describe a lot of back pain that is from facet disease to disc disease, since we know we've seen a lot of disc disease, it can lead to unnecessary surgery, which can substantially worsen the strain on already abnormal elements of the spine. So again, I think you've got to be very careful, and you've got to think about all the different causes of back pain. And in general, I think back pain is rarely caused by disc disease, even though a lot of people have disc disease. It's much more commonly caused by facet disease and some of these other changes that we've seen over time. You can get an MR scan. There'd probably be some edema in the facet joint there with the MR scan, but you know, there's nothing that's really very specific for actually what the pain generator is. So, and then we can talk about central stenosis. There are a lot of causes for central stenosis. Usually it's a combination of many factors. Usually it's due to hypertrophic degenerative facet disease. And they say thickening of the ligamentum flavum, but most people I've talked to have actually done histology studies say that it's usually due to redundancy of the ligamentum flavum. As what happens is that when you have loss of disc space height, the vertebral bodies get closer to one another, cause buckling of the ligamentum flavum. Rather than new volume of the ligamentum flavum, and that then encroaches upon the posterior aspect of the joint space here, and most of these patients will also have some degree of disc disease, either a broad-based protrusion or more focal protrusion. The bottom line is that you narrow the central canal here. And then people have varying sizes of the canal to start with, so you can actually have a congenital spinal stenosis where the canal is just built too small. And then obviously the smaller the canal, the more of these degenerative changes can encroach upon the nerve roots. Okay, so what do you think?
Okay, so sagittal and axial images of the lumbar spine. So multiple disc disease, especially L5S1, large disc. Sorry, L4, L5. L5S1 just a central annular fissure, but L4, L5 disc bulge and I think disc protrusion there and facet. I'm sorry.
Yeah. We can see that there's a lot of redundancy of the ligamentum flavum posteriorly here, so that there's narrowing really at 2-3 and at 3-4 as well from posterior disease, but then we can see the most severe narrowing is here, probably from some posterior disease, but also this focal disc extrusion here, markedly compromising the volume, the cross-sectional area of the thecal sac, and compressing the nerve roots. Excuse me. So that's central stenosis. And like everything else in the world, there's a grading system for central stenosis. Here's one where basically you have plenty of fluid around the nerve roots, and there are different degrees here. But basically, as long as there's ample CSF surrounding the nerve roots and it's bright on the T2 weighted images, that's probably not going to be symptomatic for central stenosis. Then when you get to the point where you stop viewing the CSF as well, and sometimes you'll get increased flow with pulsations, and so you'll lose the signal intensity within the fluid that is there at this stage. So basically, generally from a clinical standpoint, all the A's are pretty much normal. B, this is some degree of stenosis. And notice that the actual cross-sectional area of the canal here does not look all that narrowed, but we can see that there is a paucity of CSF surrounding the nerve roots. And we'll show some examples later of where the CSF, the size of the finding the problem is that the nerve roots are too big, which also can cause central stenosis, but that's a different disease process. And then you can also have loss of CSF surrounding the nerve roots, in this case, where you get hypertrophy of the epidural fat posteriorly. And some people are kind of born with this. Some may be associated with obesity, but you can also get narrowing here from prominence of the fat. And then when you have complete loss of CSF, this would be the most severe form, or D. So typically, I just say that there is some paucity of CSF surrounding the nerve roots on an A4, marked paucity around B, but here we don't see really an abnormal change in the contour of the thecal sac. Here we have no CSF around the nerve roots with a change in the contour of the thecal sac, and then here we really, here it's most severe form. And then you can also get central stenosis. You can also get stenosis of the neuroforamina, which we've talked about. So, Thomas, what do you think of this case?
So you have two studies, one in 2005, 2008, and looks like the central canal is increased in narrowing, and also the neuroforamina is a little bit more narrowed. Ligamentum is a little more thickened.
I think it's a little hard to talk about the neuroforamina because we're really not at the level of the foramina.
Mm-hmm.
I think we can see that there's kind of a loss of the CSF at this particular level. We're at a slightly different level and less CSF around the nerve root here. So this is in a kind of a 3-year period. The other thing to notice here is that there's significant progression of atrophy of the muscles here. So this progressive atrophy, and also there's atrophy of the psoas muscles. And again, I think that when you get this kind of atrophy of the spinae erecti muscles and psoas muscles, that itself can be a significant cause of symptoms because it's much easier to get muscle strains. And also you don't have as much control over the spine, so you're more likely to get ligamentous strains as well of the supporting structures of the spine when you get this kind of atrophy.
57-year-old, increasing back pain post-surgery, 2003, 2008. So in the 2003 study, we see narrowing. That's a T2, I think, right? I guess it could be a T1. Okay, well, I don't know if it's T1 or T2, but it's T1. So I can't really say if how narrow the canal is. It seems pretty narrow, but anyways, there's been laminectomy, and yeah.
And what do you see here that's different between the two, besides the fact that the bone is missing?
Yeah, the epidural fat is gone. Looks like scarring now, but again, I can't tell.
You can see that there's marked
Massage
replacement fit of these muscles bilaterally in the first operative case. And I think these muscle changes, very few radiologists really describe these. And I actually think they're important. And I think the lack of understanding of where the possible various areas where pain can come from, a lot of people have just forgotten all the soft tissue support structures in the spine. And I guess if you're trained to look at only the neural structures, then the musculoskeletal structures may be less important to you. Okay, so this basically, I'll take this. Here we can see a nice hypernormal, hypertrophied muscles, and then here is severe muscle atrophy. So just pointing all this out, that I really think you should comment upon the status of the muscles in most people when you do MRs of the lumbar spine, because I really think that this is a much more common cause of back pain than any of the other stuff that the radiologists normally talk about. And it's that hideous syndrome called poached couch potatoitis. And here's just a number of papers showing that, confirming that muscle atrophy can have a significant detrimental effect and a likely cause of symptoms in the spine. Some of these they use to MR spectroscopy to actually evaluate the amount of fat within the muscles. Hi, John. Is he joining us? Okay. So, hi, John. How are you? You made it.
I don't know. I had to go down next door again, and he wasn't home, but the caretaker for Margie took care of the problem for me, believe it or not.
Okay. Well, I'm glad they took care of it. So if traditional MRI techniques such as T1, T2, ADC values, and morphology are not really conclusive, and multiple studies show that they don't correlate very well with pain in the lumbar spine, what else is potentially available when it comes to MR findings? Well, one of the things that we've worked with in the past is using magnetic resonance spectroscopy to measure lactate values and other metabolites within the spine. And actually, a company that we worked with 7 or 8 years ago to get data on this is actually back now, and supposedly we're supposed to start doing studies on actual patients here in Southern California using lactate. We actually purchased a 3T Siemens scanner specifically for doing these studies in the Inland Empire, and now we may start doing clinical patients because I think they've gotten FDA approval for this technique. The other thing to look at are T1 row measurements of the discs. They estimate glucosamine concentration. Some people have looked at sodium imaging, but that requires completely different coils and a different frequency of doing imaging, and it's very hard to get good signal to noise. You have a factor of almost 100 decrease in signal to noise compared to hydrogen spectroscopy. And then some people use different tracers to measure diffusion, but now you can do diffusion fairly well using MR, but that hasn't really panned out to be all that useful in disc disease. Possibly in the nerves of the lumbar spine. And the recent paper that I showed you from radiographics are looking at ways to do diffusion imaging to evaluate the function of nerves, and that is something that may be potential. But you can see none of these are new. These were discussed really back in 2007. So there is this disease, or possible disease, or certainly possible pathologic mechanism called discogenic low back pain, which is pain due to disc disease separate from a herniation compressing a nerve root. And some people believe it may be biochemical. And as I said, we did a study which showed that increased lactate levels in disc in patients who were symptomatic correlated very highly with that level having a positive discogram, whatever that means. We can also see that some people believe that decreased proteoglycan synthesis and increased matrix catabolism may be associated with discs that are symptomatic, and that you basically hypoxia of the discs is associated with neovascularization and neoinnervation, which may be associated with symptoms. And some people hypothesize that if this is the case, then maybe gene therapy could be used to correct these. I think this is all highly speculative at this point, and though these came out a number of years ago, I've not really seen any positive results from these kind of studies over the last few years. And there's a lot of biochemistry that people have evaluated in an attempt to try to understand what actually causes discogenic pain, and I think it's still very much up in the air. This comes from MR spectroscopy studies. This was actually some of the data partly that we obtained, or we obtained data very similar to this. This is using MR spectroscopy. This is the lactate peak, and in normal discs, the lactate peak should be significantly below the proteoglycan peak. In painful discs, the lactate peak is significantly higher than the proteoglycan peak. And if you use MR to separate discs which have high lactate from those that don't have lactate, and then you correlate that with discography as a production of pain, then you can see there's a pretty good separation between the non-symptomatic discs at discography and the symptomatic discography. So this is a technique that people are in. The problem I have with this is, I think it's interesting to study because who knows where this kind of information will lead to in terms of treatment down the line. The problem right now is, so you find that the disc is causing pain, it would be a big leap to say that you should then go in and do a fusion at that level and do a discectomy when there's no disc herniation. So I certainly wouldn't use this as a reason to do surgery. But on the other hand, I'll tell you that most of the surgeons involved in this study really had that in mind and participating in this particular study. So hopefully we'll continue these kind of studies and get enough information to be able to improve management of patients with back pain. This is kind of what it looks like. So this patient had a 2-level discography. It was negative at 4.5, positive at 5.1. We can see, well, maybe there's a little bit of loss here. But if you actually notice the proteoglycan peak and the lactate peak, you can see that there's a reversal at the 5.1 level, whereas we have normal proteoglycan being much higher than the lactate peak. In fact, the lactate peak actually almost being non-visualized at the 2 levels that above it, and especially the 4.5 level that had a negative discogram. So that's kind of what the data looks like when you do spectroscopy. And some of our data was in this. This is from Noci Scanner, which is the company that's really trying to market this right now. And they only had one where there was actually a misdiagnosis on the part of the MR spectroscopy. Okay, who did the last one? Your turn. Okay.
48-year-old female with back pain radiating into left leg, rule out HMP. Okay, so there is hypertrophy of the redundancy of the ligamentum flavum at the L2, L3 posteriorly, and also we have disc protrusion at L5, S1.
A little bit of spondylolisthesis at 4.5, maybe a little bit of retrolisthesis at 2.3.
Okay. There is no significant spinal canal stenosis, neuroforaminal stenosis. Okay. Okay, so you're the kidney.
This was a patient that I actually read, and the surgeon called me back the next day and said, what about the retroperitoneal lymphoma? So this is just to remind everyone, and this is what started me having a paragraph in all my reports evaluating the retroperitoneum.
What did you say, John? What about it?
I didn't comment on any abnormality in the retroperitoneum. And
No, when he said, "What about that?" He said,
let me go back.
"What about it?"
Okay.
Okay.
This is what led me to add a paragraph in all of my reports to look at the retroperitoneum. And since then, which was a number of years ago, I've yet to see another case of retroperitoneal lymphoma. But that's the reason I added a paragraph on the retroperitoneum in all my reports. I've seen a lot of other stuff in the retroperitoneum. So I just want to remind people that there are other causes of back pain besides just the disc disease that we've talked about.
Okay, 17-year-old male with acute back pain. Spine's not too bad. Okay, it looks like there's hydronephrosis, or at least hydroureter on the right.
Yeah. So this is someone who had back pain, acute back pain, but it was from a stone.
Okay, so 82 years old male with acute left back pain. So sagittal images of multiple disc disease at L2, 3, 3, 4, 4, 5. L2, 3 discontinuation, L4, 5, L5S1, very bad with severe stenosis, central canal stenosis. And yeah, on the left kidney, definitely something going on, hydronephrosis.
So there we can see a lot of disease, central stenosis, a lot of disc changes.
Right. And same patient, acute left back pain, okay. Some hydroureter, or yeah, proximal hydroureter, severe hydronephrosis.
It looks to me like the ligamentum flavum is pressing quite a bit at that one level that you showed, John.
Well, I agree. There's a lot of spine disease here.
I mean, this is not a single disc disease. This is multiple.
Right. You got a lot of spine disease here, but the patient's symptoms are actually due to the kidney stones and the hydronephrosis, hydroureter, due to stones. Here, the stones in the left renal pelvis, and there was another stone in the distal ureter, which was probably.
Well, they can always put a cage in there and yank it out, but that still may not be the cause, would it?
Well, this was acute pain. The patient had had the degenerative spine disease for a long time. This was on top of his usual and customary back pain. Again, I just point this out to remember all acute back pain may not be in the discs and the spine.
Got it.
Just want to emphasize you have to look at the retroperitoneum. And the aorta is a little bit large here too.
If you look, you get surprised sometimes.
Yeah, and here's another case where we can see a little bit of degenerative disc disease. Go to the axial images, you can see that, and then if you follow it down, there's the stone in the ureter on the right side here. So just remember that. Okay, who's next?
Thomas.
Oh, Thomas, what do you think of this case?
Patient with excruciating back pain. There's a little bit of sclerosis at the SI joints, and yeah, there's something in the pelvis, tubular, it's on the left side. That's retroperitoneal.
Yeah, this was iliac vein thrombosis, which caused the back pain in this person.
What did you mean retroperitoneal?
About what do you? Any of the structures in the retroperitoneum of the body.
Okay, I understand the vein thrombosis causing problems, severe ones.
Yeah.
But okay.
And the others were renal stones. that I showed, and
Yeah.
lymphoma. So, okay, here we go.
A 60-year-old, right hip and knee pain, rule out fracture or stenosis. There's loss of vertebral body height at multiple levels. On this T1, I can't tell if it's acute or not. As long as we're talking about vessels and everything, it looks like the aorta has areas of dilation. Maybe the common what are you pointing to?
It's where the sagittal is, the axial.
Oh, yes, it's dissecting aneurysm, I guess, there. Yeah.
It sure looks like it might.
Yeah.
And if you follow this down, you can see the dissection goes distally. So again, there are a lot of structures in the retroperitoneum that can present as back pain. So after all this, why should we ever use MR in the evaluation of back pain? So, we can use it to map out structural changes before surgery. And the big push, I think, and I'm a little skeptical here, so I think some people could legitimately criticize me for this, but I think a huge push to do MR of the lumbar spine has really come from surgeons and hospitals who make most of their income on surgery. But so it's to map out structural changes, but now the data should make us think twice, as we've talked about over and over again here, concerning the role of surgery. There certainly is a clear-cut role for surgery, but I think it should be more narrowly defined than it was in the past. To exclude non-structural changes before surgery, so to look at cancer, to look for ureteral stones and all these other diseases that we've looked at, and to evaluate for non-disc disease in high-risk patients. So the use of imaging in patients with degenerative disease, this comes from a study in JBJS from Bowden in 1996. With acute back pain, they recommend no imaging in the first 6 weeks because 80% of people with acute back pain will resolve their symptoms within 2 to 6 weeks. And in that time frame, very few of them will actually have an emergent situation that has to be taken care of. Unless they have neurologic findings, constitutional symptoms, i.e. you think that they have a systemic infection, trauma, or known malignancy, in which case the imaging should be done more acutely to look for those kind of conditions. And chronic back pain, they recommend an MR scan to try to help evaluate the cause of back pain. We now know that I think MR is still very valuable to look for things, but I think we have to be skeptical about how we're going to handle the degenerative changes, which are the most common cause of back pain. In acute radiculopathy, again, he said no imaging in the first 6 weeks because almost all of them resolved, unless you have progressive neurologic findings, loss of bowel or bladder function, trauma, malignancy, or infection, and then they need emergency imaging. Here are the criteria from the American College of Radiology. Significant trauma means you should do MR imaging, unexplained weight loss, unexplained fever, immunosuppression, history of cancer, IV drug use, prolonged steroid use, osteoporosis. So these are primarily concerned about cancer or infection. Osteoporosis would be fracture. And even with fracture, it may cause symptoms, but if you have compression fractures, if you don't have neurologic findings, it's probably treated conservatively. For a long time, people would inject methylmethacrylate and other things into compression fractures, and there was a feeling that those patients would do better and have less symptoms. More recently, a large series evaluating patients with and without injection therapy for osteoporotic fractures have found that there's no value to it. So it's no longer recommended to do that, though there are still people who really highly believe in it. So there may be a little bit less of a need to do it in osteoporosis, but still that's listed as a criteria. age over 70. Personally, I wouldn't use that, but that's maybe because I'm almost 70. But I think they're really thinking here in terms of a high risk for cancer. Yes, John?
It's more of the pain and how it comes about. It can come suddenly, or it can come quietly or without any trauma. The thing is, you don't go jumping and doing surgery on a case like this.
Good.
Now, that 6 weeks, I'm not sure that I would go along with that 100% of the time. I would like to have an MRI if I'm suspicious enough to worry about metastatic disease or a cancer that may possibly be cured. I'm not a cancer doctor, but I do have the problem.
Yeah, right. Yeah. And then focal neurologic deficits with aggressive or disabling symptoms and duration over 6 weeks again. So these are the ACR criteria. And I think John makes a very good point concerning the concern about cancer, and that it's much more treatable than it was 20 or 30 years ago. So making the diagnosis of cancer can have a significant change in treatment. And so that's probably the reason for a history of cancer is important and age over 70 is important.
Yeah, it's pretty hard to tell a patient, I'm sorry, you're going to be dead in 6 months.
What if we make diagnosis?
I've heard that at the golf course a few times, and that really made me sick.
I think I'll go to a different course.
Well, unfortunately, I already resigned.
Okay.
But not unfortunately, I guess I was planning for a while.
So this is an article that was in Annals of Internal Medicine, and what they found is in areas where there were a high use of MR scanning of the lumbar spine compared to those that had lower use, they found that there was use of MR led to increased number of surgeries and other interventions, including epidural injections, and significantly increased costs compared to regions where MR was not used. And then here, this is the American College of Physicians, by the way. And the imaging criteria, they said, are severe or progressive neurologic deficits, suspect of infection or cancer or trauma, and repeat imaging should be based on new or worsening symptoms. But you guys remember that study from Stanford where they followed 200 patients, and when they got new acute severe symptoms, they did MR imaging, and only 1% of their total population actually showed any changes on an MR scan. And out of those who had acute symptoms, which was about a quarter of their population, only 2 of those actually had new findings on an MR examination. So most patients who have acute new back pain, the MR scan is not going to be changed compared to what it was before. Let's be aware of that. So conclusion from all this is you need to renew your gym membership. You need to strengthen the core muscles first and to keep the BMI under 25. Those are the major things that you really need to think about in people with to treat back pain. Okay.
And it was a German in 1905 that started all of this.
Yeah. What was his name?
I can't remember actually, but the physical therapists certainly know it. The therapists used that procedure, strengthening core muscles, but after a while they just gave it up in 1900. And then I don't know what happened between then and now. All of a sudden it came back.
Okay.